Tēnā koutou katoa, ko kingitanga ko tahi, ko polono o ko whakapaparanga mai. Ko otatahi toku whenua tupu. Ko hawara, ko hekateri o ku kāinga, no Aotearoa ahau. Kia motu ka ati rahi, ahau e noho ana anaenei. He kai whakahaere ko papa matua ahau, o te tima to tātou reo o, e te tahuha ora, ko Jane Goodwin ahau. Tēnā koutou katoa. Kia ora everybody, my name is Jane Goodwin and it's a privilege and pleasure to get to lead the session on shared goals of care with you today in this webinar. Shared goals of care is the first tool that's included in this package. A little bit of background about me. I'm a nurse. I worked in the acute setting across New Zealand and the UK for 15 years before taking up a role as the Advanced Care Planning Facilitator in Waitaha, Canterbury, about 13 years ago now, making me feel old. For the last 10 years, I've worked alongside the wonderful Carla Arkless to develop and lead the National Advanced Care Planning training for Te Tahuha Ora, the Health Quality and Safety Commission. We've also worked to support districts with their own implementation of advanced care planning and more recently shared goals of care. For the last 2 years, I've been working predominantly for the Commission, supporting other districts with their training as well as providing implementation expertise to the national team. And I really appreciate the opportunity to be sharing the work that we've been doing at Te Tahuha Ora that fits so beautifully with the mahi that's happening in this space with you all today. So, what is shared goals of care? Shared goals of care are when the person, clinicians, family and whānau explore the person's values and the care and treatment options that are available. And they agree a goal of care for the time, that episode of care, and if that person was to deteriorate. I like to think about shared goals of care as targeted advanced care planning. It's an opportunity to hear from the person and their whānau about what matters to them and use this alongside an understanding of what's happening with the person's health and their medical condition, and to agree a goal of care if that person's condition is to deteriorate. It's a two-part process. The conversation is the first part to understand who the person is and what matters to them and their whānau, and a decision as to the appropriate goal of care and treatment escalation if the person was to become more unwell. There may be many opportunities across a person's lifetime to have these conversations and contribute to the shared goals of care mahi. Each shared goals of care conversation contributes to their person's advanced care planning journey by encouraging them to consider what matters to them and what is important if things were to change with their health. It's a concept being implemented across the motu for patients entering the acute hospital environments, and in the constructs of what we're doing here, it's also gaining traction in the aged care sector. In the acute environment, the episode of care is generally considered the hospital admission. In the case of a person entering residential care, the episode of care is seen as the period of time that person is living in the facility. So why do we think shared goals of care? Well, it helps to ensure appropriate and necessary care through to the end of life that reflects the person's values, wishes, and preferences. It also helps to strengthen the person-centred dementia mate wari care through to the end of life. Each conversation is unique and each decision is nuanced, as each person and whānau will have a different life journey and different care priorities and have different underlying health conditions. Shared goals of care can be applied across a person's lifetime, and unlike the advanced care plan, can be developed and used to support a person who no longer has capacity to make their own healthcare decisions, which is why it's such a valuable tool in the dementia space. So when should we think shared goals of care? Across all our settings, we encourage shared goals of care conversations to happen as close to the admission as possible. Ideally, they should happen before a crisis or imminent end of life. Shared goals of care conversations might be standalone if the person hasn't had a lot of contact with the health system previously, or they may be ongoing and build on previous discussions or decisions that have happened. The opportunity to build on conversations over a period of time is particularly relevant in the aged care environment. A significant change in the person's condition or a routine review are all opportunities to revisit shared goals of care and ensure that everyone is still on the same page about what the goals of care are for the resident. So how do we do this? Well, shared goals of care is generally facilitated by the appropriate clinician or clinicians. We want to be doing it with we want to be making sure that the person's wishes are heard and that they have the people they want with them. Ideally, we'll also be making sure that if there's an activated enduring power of attorney, they are very much part of that process. We need to do it with cultural safety in a private and dignified environment and with clear documentation. So essentially, shared goals of care has 3 sort of steps as part of the process. And the first is around preparation. Preparation is predominantly something that the responsibility for it predominantly sits with the healthcare team. It's about preparing yourself, the team, the resident, and their whānau for the conversation. For yourself, it's about making sure you've considered your own implicit biases. It's about making sure that the right people have been asked to attend the kōrero, and that they know what the conversation is going to be about. So it's not sprung on them, it's not a sudden surprise that these discussions are happening. They've had time to think about and prepare. You want to be thinking about what your team and you consider might be happening with that resident's health conditions, what it might mean for them day to day, but also what it might mean if they deteriorate. It might also include thinking about what types of treatments would or wouldn't be appropriate given that person's underlying conditions and if they would be beneficial or not. It's an opportunity to think about who's going to lead the discussion and how you're going to approach the conversation. And in that preparation phase, you're also wanting to maybe think about what conversation structure you're going to use and how you're going to ensure that we're optimizing a supported decision-making approach for the resident. So Carol alluded to the supported decision-making earlier, and there are 5 steps that are part of this. You can look at this in more detail in the workbook, but essentially it's about inclusion, making sure that resident is involved as much as they are able and are willing to be, that we understand about the things that are important to them, which the shared goals of care process innately is doing, that we're respecting that person's rights to have the people that they want with them, and that these discussions are safe and held with dignity at a pace that works for them, and that we recognise that each day might be different for somebody living with dementia. There may be days that they're more able to participate than others, and we need to adjust and support as we're able through that process. So, second step is around the kōrero, the discussion. The discussion includes asking the person their understanding of what the current condition is and what might lie ahead. It might also be asking the whānau if the resident doesn't have capacity to be sharing all of this information. Asking about how much information the residents and the whānau would like about what's happening. Share your understanding of their current condition and what may lie ahead. And explore their values, what's important to them, including their current priorities, their hopes, their worries, what helps them through tough times, and what they might be willing to go through for the opportunity of more time. Now, the shared goals of care document, which you'll see is 2-sided. There's one side here. It has all these prompts on it to help lead you through that process and make it as simple as possible. You might choose to use a tool like the Serious Illness Conversation Guide to structure and support the conversation. And this has been sort of inbuilt into the process with the form, the way the questions are prompted. To learn more about the Serious Illness Conversation Guide and to see Carla demonstrating it being used to support an ARC shared goals of care discussion, there is a link in the resources, and you can also access this from the Advanced Care Planning website. Again, the link to that is in the resource pack that you can access through the site. In a dementia context, discussions should include the resident as much as is possible. However, we recognise that there are some instances where these conversations may need to be with the whānau without the resident being present. In these situations, it's important for us to be thinking about making sure we're asking whānau for what they think the resident would want, rather than what they want for the resident. So there's a nuance there, and we're really wanting to focus on what they understand the resident would want in this situation. Okay, and the final step in the shared goals of care approach is around decision and the documentation of the discussion and decision, so that people can see what has happened, the process that has gone on to reach this point. So on our shared goals of care form, this is the second side of it, you'll see there are 4 decisions that people can choose from in terms of what our goal of care is for this person. Now, these are clinical decisions. These will be made off the back of the kōrero we've had with the resident and whānau, and with the understanding that the clinical team has about what is happening for that person's health. So option A is that the goal of care is restorative. Treatment aims to restore health status to the best possible. Essentially, option A is the full shebang. We're throwing the kitchen sink at this person. We're escalating them to hospital if we cannot provide treatment on site. So we're doing all we can to optimise their health and keep them as well as possible in that space. Option B is that the goal of care is restorative. Treatment is aiming to prolong life and enhance its quality. Essentially, it is active treatment with all appropriate medically indicated interventions for that resident, but without CPR. Now, CPR may not be administered because the person may have made a decision themselves that they do not want it, either during this process if they still have capacity to make that call, or previously in an advance directive. Or it may be that CPR is not medically indicated for that person. CPR is predominantly only effective if it's being used to restart the heart from some sudden health event. If the reason the heart is stopping is because it's the end of that person's body's dying process, then CPR won't be effective and it shouldn't be used in this situation. Option C, which is one we see used a lot in these kind of contexts, is the goal of care is to improve quality of life. This is about active care on site. The aim is to slow decline and enhance quality of life. In most situations, a resident whose goals of care is C would not be for CPR and would not routinely be transferred to hospital unless comfort cannot be maintained at the facility or transfer is advised by the general practitioner or nurse practitioner. The final goal you can choose from is goal D, which is comfort whilst dying. Treatment aims to optimise comfort rather than attempting to prolong life. If residents are in their last days of life, there is a prompt to initiate te ara whakapiri. Residents who have goal D would not have CPR attempted and would not be transferred to an acute hospital unless there were exceptional circumstances. So it's really important to remember that when we're thinking goals of care, the actual onus or decision making on what the goal of care is comes or sits with the senior clinician, usually the GP or nurse practitioner. There may be instances where a resident or whānau is advocating for much more active treatment than is medically indicated. In these situations, the decision is ultimately a medical one about what's medically appropriate for that person. While the resident and whānau may not agree with this decision, shared goals of care approach and process provides a clear process for everyone to share their thoughts, to be given an opportunity to understand the expected disease trajectory, and for any divergence in thoughts or opinions to be documented so that they're transparent. People can see the conversations, they can see that they've been heard and understood, and that everybody knows that the different places people might be sitting in that decision process. Shared goals of care is a really powerful tool. It's a powerful process that brings benefit to everybody involved. We're now going to have the opportunity to see or hear from Jean, who is a manager at one of our facilities here in Waitaha, Canterbury, and she's going to share with us her experience of shared goals of care and the value it's brought for their residents, their staff, and the team involved.
So I first heard of the shared goals of care sometime June of 2020. It was actually Catherine Palmer, Nurse Maud, Sierra. So that was more or less COVID times, right? So she just emailed it to us and said, here's a link of shared goals of care. You may be familiar with advanced care planning, blah, blah, blah. And here are the fact sheets. So I had a look at it and I said, this is a condensed and concise approach until eventually I spoke to our GM and I said, I think we can get traction with this if we make this a policy. So we made it our policy in June of 2021 that it will become an official document together with the consents when the patient is being admitted. And it's been amazing. So as of now, all our residents have shared goals of care document. We usually would start the conversation by, have you got a will? Because a lot of people are very familiar with wills. You know, a lot of them are not even familiar with enduring power of attorney, some of them. But the wills is a layman's term. So we always say it. It's a will. So what do you understand about will? You know, it's where I write down what I want. You know, this furniture would go to this and so. So it's the same. We use it as the will or as an instruction of what you want to happen when you can't say it anymore. So that's just how we introduce it, and that's easy. Because it's layman, everyone understands it. Even people with dementia would understand. As much as possible, we try to involve the resident being there, but we always make sure that there's the enduring power of attorney, of course, enacted, ideally, yes. But also we also want to involve not just the enacted EPOA, but what the resident or who the resident feels is their next of kin or the support person. Because it could be the enacted EPOA of a daughter who's in Australia, but they have a very close friend who knows everything about them next door. So we involve that person in the conversation and we document that. And we simplify the terminologies. Like, for example, we would say, Sue, should you become unwell, would you like us to take you to the hospital, or would you like the nurses here to take care of you, with a big smile? And it's like, of course you will take care of me, dear. So yeah, because often it is really, really nerve-wracking for them, even an ambulance trip. Even the appointments, it's hard. And that's why we always want to make sure that we have staff to accompany them or a family member to accompany them, because it's hard. It's a change in the environment, even the lighting, you know, the smell of the environment, and any change can be quite disruptive for them. So we make sure that it's something familiar, and with that discussion, we make it light and easy, so it's not too heavy as well, you're going to die. So the wordings would be very, very different, but as I've said, it's the involvement of those people around them that would make it a bit lighter, and the familiar staff that goes with it. And the good thing about shared goals of care is it's nurse-led. So that means the conversation is led by familiar people whom they have already trusted, or they sort of like think, oh, yep, these are the people that would take care of me. They feel that there's continuity there. But what we have assured them also is that this is a living document. That means it can change, it can be reviewed. So we assure them that. And should your health status change, we will have another discussion. And at the end of the day, yes, we're documenting your wishes, but we want to let you know also that when crisis comes, when health crisis comes, we will use our facility policies and at the same time the clinical judgment of the clinicians that would be taking care of you, primarily the registered nurses and the doctors. And we might be recommending other treatment options than what you have documented. We respect that this is your choice now. It may change. And they're quite accepting of that. Yeah. And even the doctors. So what we do in our policy, should the resident or the family choose restorative for CPR, we get the doctor. So we get the doctor involved in that one. Would the doctor agree to this, or would the doctor say, no, not medically indicated? So we have about 50% that the doctor would say, not medically indicated. And then we go back to the family and say, and then they accept it now, especially if it's coming from the doctor. It has helped us a lot in terms of reducing acute, unnecessary acute, hospitalizations, because the conversations are already there. We just say, remember we had this conversation, and I think now is the time that we do the comfort cares. We can provide this, so it's more of what we can and the support that we have from the palliative care team and the GPs as well. Our GPs have been very amazing. And also, as the practitioner, it will actually make us grow a lot. It would make you be in touch with your own, I think, especially when we're talking about deaths, it's hard to make that discussion when you are not comfortable talking about it as a person. So I think you can self-reflect on where you stand about these topics, and the more you are in touch with your own personal thoughts about that, the easier it is to convey this and deliver the conversation. So I suppose it's growth for the practitioner as well, at the same time helping the families and the residents.
So thank you so much, Jean, for sharing your experience of Shared Goals of Care and what it's meant for you at your facility. I think there's some really, really key points that she shares in that space about the value it brings for the residents, that opportunity for everybody, whānau, resident, and the healthcare team to be thinking on that same page and having had that opportunity to do that preparatory thinking. So it's not in the crisis we're making these decisions. We've had some of those discussions in advance. We've done some of the thinking, and now we can still discuss where things are up to now and how this sits, but we've done some of that background work. So it's not a sudden first time up thinking. One of the other things we've heard from some of the facilities that have been using Shared Goals of Care in this space a lot is the difference it's made around complaints after a person has died from whānau as well. Because people are feeling that they've been brought along for that journey. They have more of an understanding of what's happening on that trajectory for somebody. And there's less sort of sense of like, oh, why haven't they done things? Why isn't that happening? Those discussions have happened in advance, which has been very valuable and useful. So as with all of the sessions today, the information, we've got a whole booklet around the Shared Goals of Care portion of this that's available on the website, and the links which will be part of this process. And we'll also have links to it from the Advanced Care Planning website as well. So definitely somewhere to access and use if you want to. And as part of that, there's also demonstrations around the kōrero with whānau and Shared Goals of Care space, how you might fill in a form off the back of those discussions you've had. So a real opportunity to see it in action and how it works. So thank you so much for your time today. I understand there might be an opportunity for some questions now, and someone's going to be letting me know which questions are coming from the floor, and I will do my best to answer them for you. Kia ora.
Yeah, kia ora, Jane. Thank you very much for guiding us through the first of the 3 tools for end of life with dementia. Jane, one of the first questions that's come in the comments so far is the focus of your talk has very much been on the aged residential care setting, and that's a very important setting to get this right. But it seems as though these conversations would be really applicable in other settings as well. Can you just speak a little bit about where that's up to and how confident our kaimahi listening in today can feel to apply this thinking in other settings apart from aged residential care?
Thank you, Matthew. Yeah, so I guess Shared Goals of Care has a construct around we need to know an episode of care because we're sometimes making decisions in advance for that person. So predominantly it sits in the current environment within either the acute environment, as I said, when someone's admitted to hospital, that is the defined episode of care, or in our age residential care environment, where our episode of care is when that person is living in that facility. The complexity about using Shared Goals of Care as a construct to make advanced decision making in the community is we need to be very sure what that episode of care looks like. And while the goals of care may be consistent across those time in terms of the basic themes, when you look at the Shared Goals of Care form for hospital compared with the Shared Goals of Care form for ARC, the escalation processes are different because what you might do for someone that's deteriorating with a goal of A in hospital, that might be, pushing the clinical emergency button, the MET call, having them looked at by the intensive care team, transferred to ICU, might be very different than what that looks like in an ARC environment, where it might be thinking about getting them actively reviewed by the clinical team, thinking about escalation to hospital. So they're different in different contexts. And that's some of the complexity with Shared Goals of Care as an advanced decision in the community. What that escalation might look like depends on the setting that person is in and the context of their illness. Now, that's the decision itself. The kōrero, the conversation, the discussion with the person, often using the Serious Illness Conversation Guide framework, can happen across the continuum. There is no restriction on when we can be having these conversations. The complexity in the community environment at the moment is making a specific Shared Goals of Care decision on a form. There is plans to do some work in that space for specific areas, particularly maybe initially looking at people that are an episode of care being maybe their palliative journey with a certain condition, or an episode of care being the time that they're in a dialysis unit or when they're having transfusion therapy. So we'll need to be still quite specific. Legally, we can't have a blanket shared goals of care decision that applies to everything, because we need to have some nuances around, is it medically appropriate for this situation? So, but I encourage everybody to continue thinking these conversations, because they are applicable across the board. They are part of that advanced care planning korero, that journey, that building on our understanding of what matters to that person in whānau, what they would want if things change for them, and that helps guide us to make those clinical decisions as we need to, as things change for people, whether that's in the community or in the acute or in the aged residential care sector.
Thank you, Jane. So the part of the package of the shared goals of care training within the 3 tools, that is the serious conversation guide, is immediately applicable everywhere and will just help us all. But the specific documentation, there are issues about that being applied everywhere, but that won't stop us having really important conversations. Tell me a little bit about how you
prepare someone, if they're going to then have someone having one of these shared goals of care discussions as they enter the acute setting or come into ARC, having done some of that preparatory thinking really helps them in that space. Yeah.
Understood. Yeah. How would you see this dovetailing in with that separate document or a conversation that people may have had, the advanced care planning conversation, that, you know, ideally all of us and all of our patients would have had at some point? How would you comment on how those two mesh in with each other?
I always think of advanced care planning as the umbrella term. So advanced care planning is anything we are doing that is giving people that opportunity to think about, talk about, discuss, contemplate what matters to them and what they might want if their health was to change in the future. Now, there's a number of tools and points in a person's life journey where they might think about this more. The advanced care plan is often something that people often develop in the community settings. They often do that with their general practice teams. Some may do it in other environments, but it's often a bit of a combination of time, thought, discussion to capture in their plan. Shared goals of care is still advanced care planning. It's just more targeted for that episode of care. If someone has previously done an advanced care plan, they've done a lot of that thinking already, and we should be using that to inform what we're talking to them about in terms of the shared goals of care discussion for that time. So it builds on that process. But I guess the beauty of shared goals of care, if someone hasn't had these korero in the past, they haven't done any of that advanced care planning thinking, this is our chance to use it. It's a tool that adds to the benefits of advanced care planning. It's another way that we can hear what matters to that person. It's another facet of advanced care planning, and it helps build on that. So we see a number of people that have an advanced care plan. They've had several admissions into hospital where they've done some shared goals of care discussions and made decisions in those spaces. They may have reviewed their advanced care plan and changed it off the back of where things are up to now, all those discussions they've had. And then they might continue with both shared goals of care and an advanced care plan in the aged residential care environment, if that's relevant for them. Or if they've lost capacity to be updating their advanced care plan, the shared goals of care kind of picks up that slack and helps to continue that forward with them to their ability to contribute with the things they've told us in the past matter to them in their plan or previous discussions, and what the whānau might be sharing with us now as well.
Thank you. Even in my own mind, I feel much clearer just from the conversation already today about the difference between the conversations that help us to start to think ahead and the documentation of what are you and I agreeing for this episode of care where we're heading towards, you know, cure or helping me to make the best I can, or what, you know. It's that's very clearly explained. One of the questions that's come up is to focus on the specific difficulties that can arise where that there's a lot of focus on CPR or not CPR, and the medical advice is that actually that's not a treatment that should be offered in this situation because it would harm and not help. but that is not necessarily where the person themselves or their family are at. You've already talked about how just the conversation is important because it begins to help people to wrestle with these ideas. Any other comments about how that can be managed within this process, and in particular how this can be properly documented in the shared goals of care document if we haven't quite arrived there yet, where we're all singing from the same hymn sheet, we're on that process?
Yeah, thank you, Matthew. I think one of the really important things to understand from a legal construct in the New Zealand context, a decision as to whether to administer CPR or not to someone is essentially a medical decision in the constructs of this. So even if family or whānau or the resident is incredibly keen and very much wants it, if it's not medically indicated, we are not required to do it because we have an obligation to not cause harm. CPR causes harm. It's not an inconsequential intervention. And if it's not going to add benefit, we are not required to do it. As you say, the complexity is where people are wanting something that we know isn't medically indicated. So the shared goals of care process, that opportunity to have this korero, as you say, helps to have that discussion, helps to get people thinking about where this might sit. We would be documenting absolutely if there's divergence of thinking. The family, the resident is still very keen for this. It isn't medically indicated. It is not something we're going to do, but we have talked to them about everything we will do to be supporting them on this journey. We may do a whole lot of other things. So as Jean talked about in her video, it's about focusing on the things we can do, not the thing that we're not going to do often as well, because CPR it has so much focus, but it's actually such a small part of that journey. And the opportunity to have someone dying with the people they love around them in an environment that's comfortable without people jumping on their chests or shocking them or moving them to a different location, it's a very different construct about what that might look like. So sometimes we often hear people saying that they want to, die with their loved ones with them. They want all these things to happen. And then the next breath they say, but I still want CPR. And sometimes that's a real opportunity for us to talk about the fact that CPR wouldn't enable some of those things to happen, as well as the fact that CPR only has benefit in certain situations. And on their journey of health, it wouldn't have a benefit if their heart was to stop. There's actually a whole project that's underway at the moment in Te Tahuha Ora, being led by Dr. Tammy Pegg, and it's looking at how we support clinicians to have these conversations more confidently. And we're working with a number of Māori communities to help us develop these resources. And at the moment, they're developing a patient empowerment tool with some questions and prompts that whānau, patients, residents can be using to help have these discussions and help make this clear for them where things are sitting as well. So watch this space. The CPR part of it is tough. That's why we're doing this extra project. We recognise there are complexities that sit with it, and we hope soon there'll be some new resources that can support people in that space and provide more education to help them feel more confident navigating these discussions.
Thank you, Jane. That's very helpful. I think of the different ways that you've explained that, the thing that sticks in my mind is that these are conversations about shared goals of care, not shared methods of care, and CPR is a method to achieve some goal or other. It's not a goal in itself. So I love that attention. Jane, thank you very much for your time and presentation today. I'd like